He's a reporter with the Los Angeles Times, and he's in their Washington, D.C. bureau, and he's been in the Times for 10 years, and some of you may know that I was at the Times until 2009, and he and I were friends and colleagues then, and remained in touch ever since. And one of the things that he embarked on with the help of funding from the Commonwealth Fund and from the Association for Healthcare Journalists was this examination of health reform and of access and treatment throughout the U.S. and what works and what does not work. And I think if you go to the site, the LA Times site, and you look for unequal treatment, you look for his name, you'll find some of the stories that he's done in that series. I think one of the most powerful things that he's done is he's really literally gone all over the country to look for success stories and for stories where things are not working. He's actually found a lot of success too. So unequal treatment sounds like what a lot of us think of when we see a big Sunday story in the newspaper. Oh, this is going to be such a downer. But in fact, it's, I think, in many ways uplifting because it shows you the promise of things that are working. So you went and you visited a pastor in Baton Rouge, and you visited an oncologist in Hawaii, and you visited a dog lover in Maine. There's a place called like the Culinary Extra Clinic in Las Vegas. So if you want to figure out what is the Culinary Extra Clinic, you should read the stories, because he found in all these cases, here are things that are working and why they're working, and here are things that are not working. And it's not the usual suspects. It's not things that you just on the tip of your tongue you would say. It's a wide combination of things. It's things, funding is obviously part of it, but community engagement is part of it too. People working across sectors to make things happen is a big part of it. And he'll talk about some of that today. He's also going to talk about the climate in which all this reporting has happened. As we know, the climate around health reform has been a little bit intense. And so he'll give you a discussion of it today, and I look forward to your questions when he's done. So welcome.
Great. Well, thank you very much. Can you guys all hear me okay? Thanks very much for having me. Bill, I should let you give the talk. You do a very good summation. So as Bill mentioned, I am a health policy reporter for the Los Angeles Times. Or as someone who introduced me recently noted, that is a legacy media corporation. So you're sort of in the position here, I think, of getting aviation advice from somebody who maybe works for TWA or Pan Am. So sorry about that. As Bill mentioned, I'm going to talk a little bit today about the series that I've been working on for the last year. But also, I thought I'd start out by talking a little bit about some of the challenges and some of the difficulties, frankly, of covering health policy in this current environment. So let me get started. Does this move? There we go. So let me talk first about the challenge of covering health policy. This is an actual note from one of my readers, and this was all it said in response to, I think this was actually in response to the story a couple months ago about Kathleen Sebelius resigning. And looking out at you, I probably could have put some of the saltier things that I get. They're not for my young children to read, many of them. But needless to say, the Affordable Care Act inspires a huge amount of intensity. And I will tell you that is, on one level, you don't want to be a reporter covering a story that nobody pays attention to. So it is good that people care. And I often joke that, God forbid, the Affordable Care Act should have solved our healthcare problems and settled our national debate, because I would be out of a job. Probably some of you would be too. But having a front row seat to to the national debate about healthcare over the last 5 years hasn't sort of made me feel terribly good about democracy. Frankly, it can be a little bit depressing. I want to run through for you what I think are some of the major challenges that reporters face right now covering this issue. And I think if you step back for a moment and think about kind of why is it, reading from afar, perhaps you see talk about death panels, talk about other kinds of issues in healthcare with so much hyperbole, so much mythology. And you may rightly think, well, what in God's name is the media doing? Don't we have all these reporters out there covering health policy, yet there's an enormous amount of misinformation. People don't seem to really understand the healthcare system, what's going on. So let me run through what I think are the major issues that confront not only reporters, frankly, but people who work in the health policy space in places that are maybe a little less like Washington, actually, Washington State, and more like Texas or Florida or some other places where this is such a flashpoint. I mean, number one, I think public ignorance speaks for itself. People don't understand the healthcare system. The news cycle right now is unrelenting, and it makes our job of explaining the healthcare system that much more difficult. The audience that we face is more skeptical, I think, than ever about what reporters are writing and saying about healthcare and what politicians are saying about healthcare. And lastly, the polarization now in this country, not only around healthcare, but especially, I think, around the Affordable Care Act and healthcare policy is almost unprecedented, really almost unprecedented. So let me run through in a little bit more detail for you what I'm talking about here. One of the things I started covering healthcare 5 years ago, and I like to say I'm uniquely unqualified to cover this subject matter. I studied Middle Eastern history in college, and I have no medical background whatsoever. I still don't understand huge parts of the healthcare system that I write about. The amount of ignorance out there among people about how the medical system works is really amazing. And I am sometimes taken aback and constantly struggle, frankly, with trying to understand how much explaining do we have to do in how we write about these choices that we're faced with. And take a look at some of this. I mean, this one on the right is particularly amazing. And this is not just among low-income people. This is not just among people without health insurance. This is a broad section of the population, almost 2/3 of whom don't have a basic understanding of the difference between an HMO and a PPO health plan. And I don't know what kind of health plan you have here, Bill, but I can tell you from personal experience that the guy who's covered healthcare in the Washington Bureau of the Los Angeles Times historically has served as the unofficial benefit consultant for the other members of the Bureau. And we put together a little memo every year helping people decide which health plan they should select. It is really, really complicated. And that's not even getting to issues about payment reform and how you measure quality and so forth. The other thing that is something that I think is rather new is the influence of both cable television and the internet. And I put this slide together a few years ago for a talk I did specifically on death panels. And I went back and I reconstructed the chronology of the origin of the death panel talking point and the response from the mainstream media. And you can see, so July 16th, 2009, those of you who weren't living the Affordable Care Act the way I was won't know that necessarily that was about the 6-month mark of the debate right before the summer recess when kind of the country went to hell as there were rebellions in town hall meetings across the country against the Democrats specifically and their push for health care reform. A woman named Betsy McCoy, who gained some notoriety during the Clinton era for writing a front page story in the New Republic claiming to have found all manner of horrors in the Clinton health plan, reappeared on the scene to claim that she was absolutely certain that the draft of the Affordable Care Act at the time included a death panel. And I can tell you, I remember very distinctly in this time period getting emails coming into my inbox from people saying, turn to page so-and-so of the House version of the Affordable Care, wasn't called the Affordable Care Act at the time, of the health care bill, and it says right there that, that there are death panels. Why aren't you reporting on this? And reporters generally are in a situation where you don't want to dignify every absurd claim by engaging it and even beginning the process of debunking it. I mean, A, it would be a huge waste of time. I don't sort of feel that, for example, we need to write Q&As about the Earth being round on a regular basis. But we ignored it for a long time. And it wasn't until August 10th, 2009, and that was about the same time, I think August 9th was the Washington Post, by the time we got around to writing essentially a fact check that said there is no validity to this claim that there is a death panel provision of the healthcare law. And in between that time, of course, the death panel became a Republican talking point. House Speaker John Boehner, Senator Chuck Grassley, someone who certainly knew better, one of the more knowledgeable Republican senators on health policy, were traveling around the country talking about death panels. So reporters can't in many cases, simply can't keep up with that level of misinformation. Nor necessarily can they actually convince people. Now, this is kind of a difficult slide to read, but it's, I think, actually a fascinating phenomenon. So there's an increasing amount of research that's gone on about how people consume the news and how they bring their own biases and their own beliefs to the news that they're reading. There's a phenomenon, messenger bias, for example. Researchers have taken CNN, for example, and Fox News broadcasts, and they have taken the transcripts of the broadcasts and had actors read the broadcasts against the opposite network's logo. So the CNN broadcast is delivered with a Fox logo behind them. And then viewers who self-identify as either Fox viewers or CNN viewers are asked to rate the news. And the CNN viewers who are viewing a CNN broadcast, even though it says Fox, afterwards are convinced that it is right-leaning and completely biased, and the opposite is true as well. This is an even more, I think, amazing phenomenon. So this question asked people, are there death panels in President Obama's healthcare law? And people either identified themselves as being somewhat or not very familiar with the law or quite familiar with the law. And as you can see, Republicans and independents, the more that people said they were familiar with the law, the more convinced they were that there was a death panel provision of the Affordable Care Act. And there's a researcher at, I think he may be a sociologist at Dartmouth, who's looked at this and has actually found that these people, the people who sort of self-identify as being sort of current and knowledgeable about the news, are particularly resistant to information that challenges their held views because they see it as personally attacking. And sort of we in the media have often fallen back on the fact-checking mode of trying to deal with this. The Washington Post has a fact-checker. There's an organization, factcheck.org, publishes a lot of these basically little tutorials designed to check politicians and the claims that they make. And this suggests that that might be very effective in reaching a certain kind of audience, but the people who are going to be most convinced are not going to be convinced by this. Finally, this slide, I think, if you take nothing else, if there's one slide that explains the current healthcare debate in this country, this is it. The partisan division over this law and how Democrats versus Republicans feel about it is so enormous, and it colors everything that politicians do in the way that they talk about it. You may wonder why, for example, some Tea Party Republican candidate is talking about healthcare in a way that it may make absolutely no sense to you. Now, there's some chance, I used to cover Congress, so I can say this with some, maybe not authority, but there's some chance that he doesn't know what he's talking about, because a lot of them are less than impressive. But there's actually a pretty good chance that this critic of the law may know exactly what he's doing, because his constituents, 76% of them, 3 out of 4 of them, think this is the worst thing that they have ever witnessed. And I actually think that this is something that supporters of health reform underappreciate. And that is that federal health policymaking, and the Affordable Care Act specifically, have become almost a proxy for a much larger and more fundamental debate that's going on in this country right now about the role of government. And it's not about ACOs or Medicaid or coverage expansion and exchanges. It's about whether or not government should be providing health insurance to its citizens. And you may think that that's something that has value. You may think there is scientific evidence that suggests that it is beneficial to people's health, that it may have economic benefits. But if you fundamentally think that that is not something that government ought to be doing, it's very hard to come to a debate about the value of different provisions of a federal law, to come to that debate with an open mind. And there's been some very interesting work done by pollsters who have gone out and interviewed people who self-identify, for example, as Tea Partiers about their views about healthcare. And the interesting thing that comes back is that many of them will talk about the law as undermining American values, making people not work hard anymore. And this fear, this sort of feeds into this concern about decline and the decline of values in this country. It's very, very difficult to overcome that. Very difficult, not only putting aside whether you want to convince somebody or not that the law has value, to even talk about kind of how you craft federal healthcare or state healthcare policy when the distrust of government is so profound. So, what to do about it? So, I don't presume that the LA Times or me specifically can actually change the trajectory of health policy discussion in this country, but traveling around this country and thinking about what I saw in different parts of this country, in Massachusetts and California and Mississippi and Kansas and in between, one thing that really struck me was that we don't have one healthcare system in this country. I mean, there are more than 50. You can look at it geographically, you can look at it across Medicare and Medicaid and commercial insurance and veterans care and TRICARE for active duty military. There are multiple healthcare systems in this country. Now, I was particularly interested in some of the geographic variation around here in this country, because if you go and you look how medical care is being delivered outside Boston compared to how it's being delivered in the Mississippi Delta, it's not just that those two places look different and the people who live in those two places look different. They are radically different ways in which communities have organized their healthcare system. And sort of got me thinking a little bit about maybe if that story, and if we could talk about healthcare in those terms, in sort of what is actually being done in one place and not being done in another, maybe that would help help foster a different kind of discussion about healthcare, because while the healthcare debate is political, people obviously relate to healthcare and medical care on a very personal, non-political basis. I mean, when was the last time you may have an uncle who's a rabid Democrat or a rabid Republican, and if they're asking what doctor they should do or what drug they should take, that doesn't usually precipitate a political discussion. It's usually about how do I get the best healthcare. And I thought a little bit about how we could try to get at this to try to explain some of that variation and set people's expectation differently about what their healthcare system ought to do. So that gave rise to the series that Bill was talking about and that I've been writing for the last few years. I applied for a grant in 2012 from the Association for Healthcare Journalists and funded by the Commonwealth Fund, which, as you probably know, like you guys, does some really interesting work on variations in outcomes and quality around the country. And the idea here was to sort of use some of this population health data to drive the stories about what was going on in different places, and then go out there and visit them and try to illustrate them. I'm not a researcher, as you can probably tell by now, so I don't have the capacity to analyze this data, but the thing that journalists, I think, can do is we can go out and we can tell the stories of people who are living whatever the data seems to suggest is happening. And the goal was to do that. So the starting point was maps like these. Of course, the big thing that stood out right away was the ultimate outcome data, right? Mortality. I mean, huge. And I was particularly interested in this measure of mortality amenable to healthcare. As you all know, there are different ways of measuring this stuff. We chose to focus in on this measure, which we thought would kind of try to isolate a little bit what the effect of a healthcare system was in a community, accepting for a minute that the sort of overarching caveat here is that there obviously are a lot of factors outside the healthcare system that affect why people in Everett, Washington, or St. Paul, Minnesota are living longer, healthier lives and are dying less from causes that can be prevented than folks in Baton Rouge and Memphis, Tennessee. But I mean, Everett, Washington, 51.5 deaths per 100,000 premature deaths, 169 in Memphis. I mean, that's a big difference. And of course, it wasn't only when we started digging into some of this data about what was happening in communities and their healthcare systems, it wasn't just the end. When we backed up along the process, when you looked at kind of what communities were doing, there was a similar variation. If you looked at admissions, for example, for Medicare beneficiaries to the hospital for conditions that can be treated in an ambulatory care setting, the difference in admissions, the low, was in Ogden, Utah. This was in the market, healthcare market around Ogden, Utah, 1,500 per 100,000 Medicare beneficiaries to 9,600 in Monroe, Louisiana. Recommended screenings for people over the age of 50, 26% getting recommended screenings, cancer screenings, et cetera. In Abilene, Texas, 59% in Arlington, Virginia, outside of Washington, D.C. So huge, huge differences. And then if you back up a step further and we started looking at what are the characteristics, the basic characteristics of these healthcare systems, there too a huge variation. The lowest coverage rate in the United States, McAllen, Texas. 47% of adults, of working age adults between 19 and 65 have health insurance coverage, 47%. The highest, 95%. 94, 95% in multiple markets in Massachusetts for obvious reasons. Primary care doctors, similar. The concentration of primary care doctors, which everybody believes is sort of critical to delivering basic chronic care management, good diagnostics. 44 primary care doctors per 100,000 in Odessa, Texas, 117 in San Francisco. So we sort of started thinking about, well, how can we take some of these different data points and sort of divide them into the inputs and the outputs? What are the things that are contributing to sort of what's happening on the outside, at the end of the line in healthcare? What are the things that are happening at the end? And I sort of, in my mind, sort of divided, well, we have kind of the social determinants of health. We know poverty, education, obesity, social capital, which is a really interesting one. I didn't end up doing that much with this, although I think it's kind of a really rich area of data. We gathered together some data measuring kind of how engaged citizens are. It's really interesting work being done by sociologists on this. I don't know if you guys ever heard of the book Bowling Alone, but Robert Putnam, who's a sociologist at Harvard, sort of looked at kind of where community cohesion was strongest. And there's an outfit at Penn State that actually gathers social capital data on like how often people vote, what the frequency of participation in sort of civic groups is, volunteerism, church going, et cetera. And it turned out there is some interesting correlations, as you might expect, between health and social capital. But we wanted to put those for aside and sort of focus in on the healthcare part of this. Health insurance, primary care, use of health information technology, the presence of integrated care. We hear all this talk about ACOs and how health systems are organized. Could that make a difference? As I mentioned, I couldn't do this by myself, and thankfully some researchers at Harvard, some of you may know Dr. Ashish Jha, he lent me some his grad students to help crunch some numbers just preliminarily. We couldn't do, as I said, a real thorough statistical analysis isolating and controlling for different factors, but at least to sort of help guide the reporting to sort of say, we're not going to prove causation in this series, but we can show association. We can begin to ask, hopefully, some smarter questions about what was going on. So after doing all this and kind of looking at what are the factors that are sort of seem to be most associated with, I ended up focusing on mortality primarily. Because I think at the end of the day, you ask people like what they want out of their healthcare system is they don't want to die, right? I mean, and we wanted to first sort of introduce this idea of this huge healthcare divide that exists in this country by going to a couple of places and profiling them. Because I think most people may not understand actually how big the difference really is between, in this case, we looked at Baton Rouge, Louisiana, and St. Paul, Minnesota. And I think a lot of the tendency in the discussion about these sorts of things is, well, of course health sucks in the South. It's poor, people eat fried chicken all the time, their diet's terrible, they smoke more, they're not educated. Okay. But the hypothesis here was there's something more than that people who live in places like Baton Rouge may be getting screwed twice, basically. And so I wanted to pick two places that had a connection to one another. Baton Rouge is at one end of the Mississippi River, St. Paul's at the other, but they're both state capitals, both have French names. We know there are huge differences between these places. We know that in St. Paul, people are not as poor, they're not as fat, they're more educated. But we also know that there were big differences in the healthcare system. There are more people with health coverage in and around St. Paul. There are more primary care doctors. There's more use of health information technology. And the thing I was really most concerned about was trying to get away from the idea of laying this all at the feet of poverty, that could sort of be an easy explanation. So we decided to go to two federally qualified health clinics, one in St. Paul, one in Baton Rouge, Louisiana, and look at how do these clinics deliver medical care, and how do they fit into their healthcare systems, and what does that mean for the patients who go there. And these are two places that are similar in a lot of ways in terms of what their patient population is like. 95% of the patients at the Capital City Family Health Center in Baton Rouge, Louisiana are below 200% of the poverty line, 98% in St. Paul, Minnesota. There are, as you might expect, more African American patients in Baton Rouge than there are in St. Paul. But there's way more people in St. Paul, Minnesota who don't speak English as their first language. So just to give you a little idea of these two places, Capital City Family Health Center is in the middle of Baton Rouge, which is, I don't know if any of you have been there, but Baton Rouge is a sleepy southern town on the Mississippi River that started as a port for the cotton that was from the huge plantations that line the Mississippi River, basically north to Natchez, Mississippi, and south down to New Orleans. And Capital City Family is located on Florida Avenue, which is the east-west street through Baton Rouge, north of which was the white part of town and south of which was the black part of town. I'm sorry, north of which was the black part of town and south of which was the white part of town. And those never met for many, many years, obviously. Open Cities Health Center is in a place called Frogtown in the center of St. Paul, Minnesota, a historically black part of that city, an industrial part of St. Paul. It's in the shadow of a public housing tower that is now primarily home to immigrants from East Africa. The Twin Cities in the last 2 decades have had a huge influx of Ethiopian and Somali immigrants, and of Hmong, which is a minority from Southeast Asia, many of which came to Minnesota after the Vietnam War. The interesting thing about these two places is that not only were the populations similar, but the outcomes were very different. And if you look here, we used HRSA data, which was data from that the federal government gathers on all federal clinics that tracks kind of what the outcomes, some of the outcomes are for patients who go there. And what you can see is that across the board, more female patients get cervical cancer screenings, more children receive recommended immunizations. The coronary artery disease patients are more likely to get cholesterol therapy. Diabetic patients are more likely to have their blood sugar under control if they're at the health clinic in St. Paul. So what is going on there? So I went down to the clinic and spent some time in the health clinic in Baton Rouge, Louisiana, and the things you hear there are chilling. You hear, of course, the things that people talk about that's difficult to serve a poor population. But the thing that was really striking is it's not just difficult because people drift in and out. Poor patients are tough to take care of. They can't get appointments for people with specialists around town because there's such a huge uninsured population there that the physician community is understandably reluctant to take on a huge burden of non-paying customers. So it was very difficult to do that. Here, this is what one of the doctors at the health center said. the nurses and the doctors there talked about being isolated from the rest of the healthcare system. There obviously are big hospitals in Baton Rouge. Baton Rouge is kind of interesting because unlike a lot of southern cities, which are sort of mid-sized southern cities, which have been sort of in slow decline for decades, Baton Rouge there's a huge oil boom going on, petrochemical boom going on in Louisiana, so there's growth in that sector. And it's the state capital, LSU is there, which is a huge economic engine. But the health clinic and the other people who cared for these populations in Baton Rouge were isolated, not part of this community. And the result was, people talk about, everyone has stories of not being able to get care. Everyone seemed to know someone. I spent some time with Reverend Melvin Rushing, who is a pastor of 2 African-American churches around the clinic. And I went to Sunday services there and stopped people afterwards. Everyone has a story of someone who has had some terrible complication from diabetes or heart disease, usually something that could have been dealt with if it had gotten attention through regular primary care. Now, the medical director at the health clinic in St. Paul, by contrast, who was himself from the Deep South, African-American elderly physician from a part of Texas near the Louisiana border, said in St. Paul, they rarely have problems finding specialists to take care of their patients. He spent time there with nurses and doctors, and patient after patient would come in and they'd say, the common line was, we'll get you set up. And they'd set up, with a pulmonologist, or your child has asthma, you need to go see a pediatric specialist. The appointments are able to be gotten. The clinics work together with one another. Around the Twin Cities, there's an effort right now, for example, to unify the care management capacity of the clinics so they can better manage the care in Minneapolis and St. Paul. They use electronic health records to track the outcomes of their patients, which is something that Minnesota has one of the most highly developed electronic systems for tracking medical records called Minnesota Community Measurement. They've been doing it for about 15, 20 years. Doctors, health insurance companies, major employers in the Twin Cities have been doing this as a joint exercise for several years, tracking it. That's not happening in Minnesota. It's just not happening. And not happening in Louisiana. So let me wrap this. I have 2 more stories, so I'll go through these relatively quickly and then we get to your pictures, questions. But we next wanted to try to find a community that was poor and yet did very well, to sort of say, what is going on? What is going on with a community that effectively punches above its weight class? And this was Maine. Now, northern Maine has a lot more in common with West Virginia than it does with Boston, Massachusetts. It's a pretty poor place. It's rural. A lot of the economic vitality of the place has really diminished with the demise of the lumber industry up there. It's just not a lot going on in northern Maine anymore. But when you look at the interesting thing, when you look at what's going on, this is a measure with health there. Look how well Bangor, which is sort of the health market in northern Maine, does compared to its peers on these relative social determinants. Similar obesity rates, it does the best. Third best, college education. Smoking rates, and look at poverty. These are places that have similar poverty rates, but look how much better Bangor does. So what's going on there? Well, it turns out if you talk to people about what healthcare is like in Maine and you go up there, it is a community effort up there. Maine was one of the first places where Jack Wenberg went when he started his work at Dartmouth to go measure what was going on in different communities up there. And the Maine Medical Society, 35 years ago, brought physicians in the community together, in the state together, to start examining what they were doing and why, in his case, very interestingly, why it was that women in some communities were getting hysterectomies at a hugely different rate than they were in other communities. And that spirit carried through to create a system of electronic health records like Minnesota. There has been a Maine, like Minnesota, has a very highly developed quality tracking mechanism. And the medical systems there have used community care nurses that travel around and visit patients it's become a key part of the healthcare system up there. I spent some time with Sally Patterson, who is herself like a 4th or 5th generation Mainer. Her great-grandfather drove the first fire truck in Bangor. And she spends every day, she's a former intensive care nurse. Now she travels all across northern Maine, visiting some pretty sad cases, frankly, of people who are diabetic or have other chronic diseases and need help managing their diseases. And with the exception maybe of Vermont, there is no other state that has developed such a huge infrastructure of delivering medical care in this way. And again, you are not going to see that if you go to Texas. You're not going to see it in Louisiana. You're not going to see it in Florida. It doesn't happen. Now, this is a harder thing to measure statistically, but when you talk to patients, you find patients who realize their expectation about what their medical care is radically different than what it is when you interview a patient in other parts of the country. The third part of this series, and this is the last one I'll talk about because the Vegas one just came out yesterday, so I haven't predated my slideshow, was Hawaii. And Hawaii is interesting because for 40 years, Hawaii had near universal health coverage. People don't sort of realize that because Massachusetts kind of became the bright, shiny thing a few years ago for obvious reasons. But before there was Massachusetts, there was Hawaii. 40 years ago, the state passed a law that required employers to provide health coverage. And the interesting thing in Hawaii is that the statistic that jumped out at me that I read about Hawaii was that Hawaii had the highest incidence of breast cancer in the country, but the lowest mortality. I thought something must be there must be sort of something interesting happening here. And could this be tied in any way to the culture of health insurance coverage there? So in addition to always wanting to get a junket to go cover something in Hawaii, I thought it would be a good idea to go out there and sort of see what was going on. And again, I spent some time with a primary care physician in a cancer center in Honolulu. And again, the interesting thing is the conversations that medical providers are having with their patients are different. This guy took over Dr. Randall Suzuka. He's, I think, 5th generation Hawaii. His family came from Japan to go pick sugarcane in the 19th century. The plantations, the sugar plantations and the pineapple plantations in Hawaii historically provided their workers with medical care. And a lot of people you talk to in Hawaii attribute the law that Hawaii passed 40 years ago, the Hawaii Prepaid Health Act, to that tradition, the expectation that the community had that employers would provide health coverage, which was more deeply ingrained there than almost anywhere else. So he took over a practice actually that was started by a former plantation doctor. And again, almost never is there a conversation about how do you delay care. The Queens Cancer Center, which is the largest hospital and largest cancer center in the state, 99% of the patients that go through there have coverage. And Queens has terrific outcomes. Now there's some debate about the degree to which the genetic makeup of the state may play a role in that. It turns out that Okinawan Japanese women have super genes when it comes to breast cancer, seriously. But the clinicians who you talk to and the people at the hospital also talk about being able to do things that they can't do elsewhere in the country. They have a very extensive, for example, survivorship program for people after they complete their care. They have a very extensive navigator program to help patients go through the system, all of which is funded independently of the revenue from the medical care. And they're frank about it. They say, we couldn't do this if we had large uncompensated care. There's virtually no uncompensated care at the Queens Medical Center in downtown Honolulu, which was founded by the Queen. And again, patients talk about a difference. This woman was, Myra Williams, was from California originally, actually. She moved out there 30 years ago. She was diagnosed with early stage breast cancer and it was treated. And before I went there, I interviewed her and I asked her, did she ever think about going back to California? And she said to me, have you ever been here? So needless to say, she's not going back. So I'll stop there. We have a few more stories coming later this year, so stay tuned. We're going to look a little bit further at some other metrics about quality of drug prescribing. Arizona has some very interesting experience with expanding and contracting health coverage, which has had some interesting impact on mortality. Some research is suggested, and then I'm hoping to dig in a little bit to some of the cost issues. So, sorry, I went long. So I'll stop there and take your questions. There's the, our website was supposed to create a very easy page for people to find, and they didn't. So maybe Bill's suggestion for just Googling unequal treatment if you want to read the stories is the better way to go. Yeah?
Are you going to write about Washington State?
I don't have any plans to at the moment. Washington State, though, was another. So the high flyers are New England, the Upper Midwest, and the Pacific Northwest. And there actually are some really interesting. There's some places in the Pacific Northwest, like northern Maine, that are relatively low income, but do quite well on measures of health. So I thought about doing those as well. Though Bangor sort of beat it out because it's kind of such an economic basket case up there that it seemed like a more compelling place to sort of write about. That's right. Probably more than Maine now. Yeah.
Were you thinking of looking at any like Native American reservations as far as their healthcare goes?
So, no, I haven't. I mean, I think it would be really interesting to do. I mean, Hawaii is sort of interesting in the sense one of the things that's interesting about Hawaii, and that kind of I simplified this, and not to suggest that Hawaii is Shangri-La in all ways, but I mean Hawaii has struggled for a very long time with trying to improve health of Pacific Islanders and Native Hawaiians, and they don't do very well at all on some of these metrics. So I think it would be really interesting. I mean, do you have any thoughts about kind of what would be a good way to get into that?
Not exactly. I'm from South Dakota originally, and so we have some of the poorest counties in America as far as reservations go. And so I would just think it'd be really fascinating to look at the difference, especially if you look at, even within the state, how much the healthcare is different between those counties, and then you look at like Minnehaha County, which has Sioux Falls, the largest city in the state,
Mm-hmm.
and the healthcare there is phenomenal. They have two booming hospitals.
Right.
So I think it'd be kind of an interesting story. I'm not exactly sure how you go about it.
Yeah. Oh, I know it's pretty bad.
I was living in rural Wisconsin at sort of the height of this debate, and the incredible thing to me about that area, which is largely poor, Republican, very sick, very obese, diabetic, all the rest, was that, okay, it's one thing for, John Boehner to be talking about death panels, he definitely can afford his own health insurance. But the amazing thing talking to the people in Wisconsin was that the people who were most in need of health care that was paid for them by somebody else were the most personally resistant to it, in my experience at least. And that there was this amazing, again, part of the idea of the government not interfering into your life. There was the idea that they would refuse health care even if it were offered to them. And I'm wondering how stories like this or the media could possibly help try to reverse that mindset, or to get these people access to the care that they need when they themselves are resistant to it.
I mean, I don't know exactly, but I mean my hope is that. I mean, honestly, until I started covering healthcare, I didn't know how to have a conversation with my doctor. I didn't know what it was that I should expect for myself, or my parents, or my wife, or my kids. What it is that for example, that if my doctor made a referral, that it would be nice if the other doctor could see my medical record. Or that if I was on 6 or 8 medications, that I didn't have to show up with all the bottles of medication every time I went to the doctor because the physician couldn't track that. Or that there was no way for my physician to actually, if I had diabetes, to look at my record and say, hey, have you gotten your foot exam or your eye exam or all these other things. And my sense is that I'm not from a place like that, although I started my career in Duluth, Minnesota, so I know that area, is that people don't, I don't think most people have an expectation of what the medical system should do. And I think that's the thing that distinguishes places like Hawaii and Maine and Minnesota and the Pacific Northwest, those places where the community's expectations have been changed because sort of forward-thinking clinicians or even community leaders who are not specifically delivering medical care have thought that there's a better way to do this, and they're doing it. And my suspicion is that if people's expectations change, that they may demand different things from their medical system, and that in turn can lead to sort of some improvement. So it's kind of like going this way instead of going over the hill, kind of going maybe around it. But that's just a hypothesis. Yeah.
Related to that, one thing that was fascinating was the difference you described between the doctors and sort of their social networks. Like you were saying in Baton Rouge, the ones in the clinics felt really isolated compared to being very connected in Minnesota. Did you observe similar network differences in the patient populations?
Well, that's interesting. In terms of what you mean their relationship with other doctors or
Either with other doctors or, I mean, I guess it maybe was in your comment about in Hawaii, you just go to the doctor and get help when you get sick. Sounds like sort of a social norm. But was there?
Well, I think there certainly was, the patients I think certainly had a different expectation. I mean, I had a lot of conversations with patients at the clinic, for example, in St. Paul, who, would have some version of, they'll hook me up here, they'll take care of me. I feel like, they look after me, and a sense of trust. Yeah, and that's not to say that the patients in Baton Rouge were not grateful for the care that they were given. But my sense was that there was much less of a feeling of connection between the patient and the broader healthcare system, and that was sort of that was a little bit of the difference. That there was more of a resignation to sort of being bounced around. Baton Rouge is sort of, Louisiana specifically, is interesting in another way because Huey Long, when he was the governor of Louisiana, built a statewide charity system in Louisiana. So there were a system of charity hospitals, a big one in New Orleans that was destroyed in Katrina. There was one in Baton Rouge and other cities as well. And they became, they were started obviously as a system to provide health care for the poor, primarily for blacks. But they ended up becoming like a separate and not equal medical system. And Governor Bobby Jindal, who is a very ideological Republican, set about privatizing them and created an enormous amount of political divisiveness in the state because the African American community, though they were not being served particularly well for a long time by that system, it was run by Louisiana State University for a number of years, considered it to be their system and they felt connected to it. And I don't know to what degree that actually may have contributed to quality health care. I suspect not terribly, but when that was taken away as well, they shuttered the charity hospital in Baton Rouge, and the whole system was foisted onto a very large Catholic system called Our Lady of the Lake, which was trying to absorb it now. That feeling of dislocation from the medical system was certainly much more exacerbated.
Given the differential rollout of ACA, largely by state, but even how they're going to administer it in different localities, I was curious to hear, are there any particular communities or areas that you're really excited to cover and see how the implementation goes? And maybe it's the same thing, but I imagine there are a lot of really interesting stories on some of those border states that are and aren't implementing ACA or picking and choosing one component. So just hearing your thoughts on that.
Yeah, definitely. I mean, one of my competitors, the New York Times, had an interesting story. You may have seen it today about Texarkana, Texas, and Arkansas. I mean, I'm quite interested in Kentucky. I think Kentucky, obviously, if you look at the states that are expanding Medicaid and those that aren't, and you look at what their health outcomes are, I mean, we're in a position now because of what the Supreme Court did where the divide is going to get wider before it gets narrower, because the states with the best health are also expanding health coverage. And those that aren't, for the most part, are resisting. And, you know, I mean, it's pretty clear at this point that there's a link between health coverage and health. Although there's, interestingly, still some debate about the academic research. But there are some places like West Virginia, Kentucky, Nevada. The fourth story, which ran yesterday, looked at Las Vegas in part because Las Vegas has terrible health outcomes. It's just a legacy of terrible health. But it is enacting the coverage expansion under the law, Nevada is. And there's some interesting, as Bill alluded to earlier, some interesting efforts by the Culinary Union there to put in place some models of primary care and chronic care management that are like a hallmark of what's happening in Maine and Minnesota and other places. And so I'm interested in these kind of places that are doing that to see, are we going to see a difference? Is Kentucky going to pull away from Tennessee? And like, how long is that going to take? The one thing I think that I'll be careful with that is, and frankly, I was talking to the head of the Kentucky Health Insurance Marketplace, Connect, who said they expect their health statistics to get worse before they get better. Because as people come into the healthcare system, there's going to be this huge undiagnosed disease burden that will be picked up. So it probably will be a while.
I was wondering, in northern Maine, the quote that you had from the nurse seemed to indicate that their interventionist policy or hotspotting, whatever you want to call it, was saving money. Was that, do you know of any studies that were done?
So she's a little bit, she's a bit self-interested in this case, because so the community care team program that she works for is jointly funded by CMS, the state through its Medicaid program, and the commercial insurers. And it's a limited program, so it has to be re-upped. So they're in the process of trying to demonstrate value. I will tell you that, so she works for EMHS, which is the far and away dominant medical provider in northern Maine. And I should also say that while the outcomes and quality are terrific in Maine, Maine has a much bigger challenge with cost. And one of the issues there is likely related to the concentration of hospitals in both northern and southern Maine. There are a couple of really dominant medical providers. But Bangor had one of the most successful pioneer ACO programs under the Medicare Shared Savings Program under the ACA. They were one of the top performers both in measure of quality and also in terms of cost. But it's still, I think, year 2 or 3 for this particular thing. So there isn't, I don't think there's any cost data yet on the broader expansion of this beyond the Medicare population. Sure.
This is a question about a different tack. I was wondering about, because oftentimes, so Bill's team, like, they take our research and help write a bit of a report or press release that goes then to people all over the world. But what I'm curious about is either with that press release in hand or without that, how do reporters look at research, decide how and what to report? How does research come to you, and what do you do with it?
So if Bill writes it, I just write it up. So it's interesting, you know, we don't. So there's a science desk. We have a health and science desk in LA, and they are. I think it's a much clearer kind of expectation that one of their major responsibilities is to write up health science and medical research, like, you know, a new drug, a new study shows, you know, you should or shouldn't get mammogram. Health policy writers, like we have a much, the standard is much more gray, and I don't write that much health policy research for the general newspaper, But I think this is beginning to change sort of as health policy, I think, becomes something where there's more of an expectation that we should have the science in the public debate. And so you're seeing, like, for example, you know, the Washington Post has a blog, Wonk blog, that was sort of designed explicitly to sort of get some of this stuff out. Now, Ezra Klein, who started that, it started Vox, and Sarah Cliff, one of my colleagues, does a lot of work on that specifically. I'm still trying to figure out when and what to write when one of these reports crosses my desk. And I think that, I mean, the challenge a lot of times with the health policy stuff is that, unlike a medical breakthrough where there's sort of this gee whiz quality to, oh my God, I can't believe that they finally cured cancer or whatever. You know, we don't have quite that in population health. No disrespect, I love the stuff, but like, I don't know if my readers may have a tougher time with that. But I mean, your stuff has gotten tremendous response when we've done some of the stuff with life expectancies. The stuff that, you know, that I find particularly sexy, if you will, is some of the data which sort of puts the United States in a global context, you know, puncturing this myth about our exceptionalism vis-a-vis healthcare. I think has been sort of a enlightening and engaging way to kind of get some of that data in. But, you know, if I write a story about the latest, and I did, about the latest study about links between the Massachusetts coverage expansion and declines in mortality in Massachusetts, which I did write up, I mean, that goes buried way inside the paper. But I will do it because I think that's, you know, we're having a national debate about coverage, so it's worth doing that. But it's a challenge. Sure.
I'm just, so I was literally writing this before you asked it, so that's awesome. So, like, what would be the types of data? What would be the types of research that you think would be able to would help you tell your story in a more informed way, but also in a potentially sexier way? What would be the information in the data that would be helpful?
Well, I think the linkages, I mean, what I tried to do in the story was to draw some connections that I basically had no business drawing, right? I mean, I was not proving causality, but there's a sort of an implied causality in a lot of what I'm writing, you know, truth to be fully honest, right? But I think since so much of the national debate right now is about what's the recipe for achieving better health, that I would certainly be interested in more research that actually did look at kind of links between various different health characteristics and outcomes. I mean, for example, one of the things that I was really, really interested in was integrated care. Everybody, you know, you go to any health conference, any medical conference, anywhere in America, and half the panels are about how integrated care and, you know, Don Berwick and IHI and all the stuff that they're doing with the triple aim and how you kind of coordinate care, et cetera. It's really hard to actually kind of measure what is an integrated care system and what's not. And at the beginning of the research process for the series, I used some survey data from the survey that the American Hospital Association does of its members to try to kind of measure how concentrated or how prevalent integrated care was in a particular market, and then sort of look at that relative to some outcomes. And it didn't work because we couldn't, I was working with Ashish on this, we couldn't kind of come up with what is the right way to define like what an integrated system is. But anyway, you guys would be much better positioned to sort of look at that than, you know, hack like me. So I would be interested in learning more about that for sure.
So why don't we have one more question, and then I'm sure that if you want to follow up with Noam afterwards, we'll stick around. But is there just one last question, maybe?
Yes.
As a journalist, how do you feel about the fact that this reporting had to be supported by a grant, even though you work for a private company?
Well, so I feel great about it. No, so the grant was not very large. it should be set. It was $4,000. So it paid for some of the travel, but not all of the travel. But interestingly, I mean, the LA Times used to turn up its nose at this kind of stuff, and we now have the Ford Foundation. I mean, this was small potatoes. The Ford Foundation is funding 2 whole reporting positions for us. They actually pay the salaries of our one of our correspondent in Rio de Janeiro or Sao Paulo in Brazil, because they have an interest in Latin American issues, and our Phoenix bureau, because they have an interest in border issues. So, look, I'm all in favor of however the journalism can get out there within means. I don't have a problem with it. You guys got any extra money?
Okay, well, thanks.
Sure. Thank you guys very much.